Good evening, everybody, and welcome to another edition of Clock Talk with Dr. Greg Brannon. For those that are regular listeners, you know that we do 15-minute segments and we rotate topics. Tonight, we're going to have an all-encompassing women's health topic tonight, and we're going to go for a full 60 minutes. So on that note, we're going to cram 4 Clock Talks into one tonight.
Sounds good.
But stick with multiple topics within female health. How you been? How's the day going so far?
Oh, fantastic. We're busy at work, reading a ton of stuff, preparing for our education of patients. So yeah, I've been reading a lot. It's been great.
Great. Well, we had some questions from some of the viewers that had populated prior to the start tonight. So I'm going to start right away with the first question. What is the connection between premenopausal, menopause, and mood disorders?
Yeah, this is really interesting. I was a gynecologist for around 28, 30 years. In fact, that's what led me to starting Optimal Bio is the replenishment of hormones. Menopause first off, menarche is when your cycles start, roughly 12 to 14 years of age. Menopause is when they stop. That's a clinical definition, 1 year of no periods. What that means is you're not ovulating. An ovulation cycle that prepares the body to become pregnant the beginning of it's a 28-day cycle on average. The first 2 weeks of that is the proliferative phase where the egg you got about 3 million eggs in the ovary that are fighting out every month. About 4 eggs battle it out as they get bigger. Those are the cysts. Around day 12 or 13, when they're proper size, a hormone called LH of the brain changes from proliferative phase to luteal phase or secretory phase. And then your body starts making progesterone. The progesterone's whole function is to promote gestation. So it goes up. If your pregnant continues going up, it going down causes withdrawal of the cycle. So a cycle is actually a non-pregnant state, okay? So there are benefits to these hormones other than having a baby. The most abundant active hormone in the human body is testosterone. In a woman, whoa, Greg, I'm a woman. It's a male hormone or female hormone. No, that's a terrible phrase. Testosterone is a human hormone. Estradiol, the most potent estrogen that's made from the ovary, comes 1 molecule over from testosterone. So menopause is when you stop for a year or the FSH is above 23, the brain, it's a marker. When the brain tries to make the ovary make an egg, and when that egg stops making estrogen, the brain tries to override it by making more hormone. It can't, but it tries. Those can happen 5, 6, 10, 12 years before you stop having cycles, because an ovulatory cycle. So postmenopause is important to understand. I don't believe there's a time frame of postmenopause. Making no eggs is menopause for the rest of your life. So 40 years of your life, you don't make eggs. So you never through it. The symptoms become less, but that does not mean that the processes to the brain, the bone, the heart, the breast are not halted in its state. It gets more degenerative over time. So menopause is a natural state, but there are some sequelae such as osteoporosis, dementia that may be pushed or hindered out further away if you replace with hormones.
And what about the mood disorders?
Mood disorders are interesting. Testosterone, that's the happy hormone. And estrogen is, I'll say, more of the moody hormone, but it's not just estrogen per se. There are 3 estrogens in the body, E1, E2, E3. E1 dominates in postmenopausal state and dominates from fat. E2 is from the ovaries we talked about. E3 is made by the placenta when a woman's pregnant. But there's 3 pathways in which to eliminate estrogen. I'll call them simple. They're numbered 2, 16, and 4. And there's 2 receptors, an alpha and a beta receptor. They have, let me go into that more detail later on, but basically beta the beta receptors sort of negate the alpha receptors. Alpha is more growth, beta is more regulation of growth. So the flexibility or the variability of the estrogen is most likely the mood disorders. But it's important to understand there's a estrogen cycle we have. So picture our ovary makes it, men, we get our testicles make it and our adrenals make it, but our body makes it from these gonads from testosterone, makes estradiol. Estradiol then goes one of those 3 pathways into your gut. Then based upon certain bacteria in your gut, that has what's called beta glucuronase, will actually reabsorb the estrogen, which you want to do, but not too much, not too little. That's why this whole cycle is very important. The production of it, the utilization of it, the elimination of it, and the recycling of it. That's why all has to be looked at.
So if let's
You
say
can, you can be moody because your bacteria is bad in your gut.
okay, so it's more of a gut issue.
Yeah, it can be because that if you have the wrong bacteria in there, you may be absorbing too little or too more of your own. It's called intrahepatic circulation. You may be having too much of it. So you have to have the best plan is you hope you eliminate down the 2 pathway, because the 16 pathway and the 4 pathway, higher those are, the more chance it appears to have cancer at the alpha receptor sites. Birth control pills go down that pathway. Premarin goes in that pathway. Bioidentical with DIM goes down the 2 pathway.
So some of your patients in the past when you were OBGYN, and now obviously patients that are going to OBGYN today that are suffering from mood disorders are given drugs that will alleviate a symptom of mood, but it's not solving the problem.
And do they even work? The hypothesis behind the SSRI has been destroyed because it's, again, where is serotonin made? They're putting these SSRI blockers in the brain to slow down the reuptake of the serotonin. The theory is make you feel better. And they're doing it in the brain. But 95% of the serotonin is made in the gut. It's a gut issue. And that's the thing about it, is that's why the food we eat, the bacteria in our body, our hormone balance is very important. But the big thing about these mood disorders is it's not in their head, it's real. These are changing. So women they have their 30 years of production, and boom. And all these things changes. Hot flashes. Hot flashes are a sign of low estrogen, which it leads to a sign of endothelial dysfunction, which, oh, by the way, a Harvard paper from 3 years ago increases heart attack 200%. So it's not a nuisance. And you take these SSRIs that block the thermoregulatory of the brain, you're getting rid of the symptom, but it's not the root cause. Again, I use this all the time, and I know it sounds repetitive, but you have 2 types of diabetics, a type 1 and a type 2. You would tell the type 2, eat better, exercise. You would tell them that first, lifestyle changes. You would never tell a type 1 that first, because the type 1 does not make any insulin. You give them the insulin and then eat right and exercise. And I believe this hypogonadism in both men and women of testosterone and estrogen is a production if you don't have it or have enough that you used to have. And that's leading to sequelae of mood disorders, belly fat, libido desires, all these things. And all the medication we have out there, they don't cure anything. What they do is mask symptoms.
I failed to mention before, for those that are joining us tonight, if you do have a question, please put it in the chat and we'll be happy to share it with Dr. Brannon.
More questions, the better.
Second question, can a woman who is approaching menopause be supported with estrogen even if she still has a cycle?
Yes. And here's why. It goes back to our FSH again. The standard is you don't treat unless you have 1 year of no cycles. But the problem is the symptoms happen so much earlier. So if the FSH is above 23, that's a case. But it's important to understand that replacing testosterone actually has benefits, even not giving estrogen. So I don't want to go too much estrogen. There's a sweet spot for estrogen. So there's a seminal paper done in 1985 that showed a testosterone independently, estrogen independently, and together. And estrogen by itself was the least beneficial. It was on a symptom test. What surprised me was the testosterone was superior to both the testosterone and the estrogen together. They're close, but the testosterone alone was superior because I believe the conversion to the estrogen. But there are the benefits of having some estrogen if you have in the proper range, because certain fibers in the brain are very important for anti-dementia, anti-Alzheimer's. And in a woman's private areas, as they mature, the bottom does not have to get older so they can urinate and go to the bathroom properly if that lining stays nice and thick and proper. And estrogen with testosterone and progesterone does optimize that.
49 years old, having PMDD symptoms around cycle, never before had these symptoms until a year ago, heightened anxiety and joint pain. Will these symptoms continue to get worse before menopause? And what is the likelihood of these symptoms continuing post-menopause?
Probably they'll learn to deal with it more over time, but yeah, I don't expect those to go away, because I think the cause of that, when you look back at anxiety and depression, there's a great paper done in the NIH in 2013 showing the best treatment for anxiety and depression in both men and women wasn't SSRIs, was actually testosterone, because it does a few things. It works. Steroids work Insulin's a steroid, testosterone is steroid, estrogen is steroid. They work two ways. One's called genomic, one's called non-genomic. Genomic is where it goes into the DNA and actually causes called transcription signaling to make more proteins. And it also works on the membrane that actually signals how you feel within seconds to the brain. So a woman loses 50% of her testosterone by the age of 40. That's what most of mood swings can. This be very simple. Testosterone is the happy hormone. Okay, happy hormone. The flexibility, the variability in the estrogen are the moods. So we know in our practice, roughly 70-75% of patients who come to us on antidepressants, often about 4 to 5 months when they get their hormones optimized.
So if this individual was being treated with BHRT,
I think they're pretty comfortable they'll improve. We have a lot of psychologists, psychiatrists in our area refer to us for this.
let's go a little bit younger.
Okay.
Another question is, if somebody's, say, 33, 34-year-old female is being treated with BHRT, can she still get pregnant?
Yes, but it's not recommended to give it while she's pregnant. In fact, I started doing hormone replacement therapy first in my postpartum state, because when the hormone levels of a pregnant woman are very high, when you deliver the placenta, they drop immediately, and that's a big change, as well as the thyroid. There's an interchange between thyroid and sex hormones that are very important in the postpartum state. So but my thing about this is I just quoted the standard care. You do not give steroids when you're pregnant. But there are cases you do use steroids. You give progesterone for premature labor. There are certain reasons why you do this. But my thing is this. Testosterone has been shown is 200 to 400% lower than it was 40, 50 years ago. So women back then, the levels they were at then are what we treat you today. We don't give you super physiological levels. We put levels that were optimized 50, 60 years ago. We have that data. So my thing, if you had zero testosterone and I gave you testosterone, I'm only going to give you a gram a generation, but the standard is no, so we don't. But it's very interesting. In the last few years, to increase IVF success rates, they're adding testosterone to that protocol, which makes sense because the actual follicle, when it's maturing in the body in the normal cycle, it makes testosterone first to actually seed the ground of the germinal layer for the estradiol to work. But the standard is no. But again, I spent a lot of detail on this when I draw the pictures and how you do that. So we do it immediately postpartum very fast, but when you're pregnant, no, but you could be on it and get pregnant. Yes.
Okay. There's no harm.
There's been no data at all on that.
Right.
Now, again, they do compare, Jim, some non-human masculine hormones, say bodybuilder ones, that could masculinize the female of baby. Mm-hmm. So the answer is yes, but we're talking physiological levels of natural human testosterone.
And just quickly, give an example of a physiological level.
Okay. Again, today it appears, Dr. Mark Richards' book is great on this as well, goes through a lot of data on that. We're looking at the bottom 20 percentile when symptoms are severely low. In a man's, it's roughly under 200. Under 300. A woman's 25 is equivalent to that. So today's range, what you look at, but most range between, say, 5 and 50. When I was in school, the range was roughly 70 to 200. So, and that's 80% of the population at that time fall in that range. So I hate the word it's healthy. That's what that population shows. So a physiological range I'm doing is I'm looking back at the earliest data from the 40s and 50s and what they were then in the pre-phthalate area, the pre-plastic area is what I call it. So those are not levels where I'm giving a woman a level equal to you and me of, say, 5 times that dose.
Okay. Kind of switching around a little bit. Diet. Seems like there's been a craze over the last few years about this intermittent fasting. Now we're hearing that, potentially for females, postmenopause is probably not a good thing. So talk to us about intermittent fasting, what it does to the body, and what about females that are doing it after menopause?
Yeah, I love intermittent fasting, and I'll go through the difference between a man much easier than a woman. A cycling woman is very, very much more difficult than a man. A man, we eat 4 to 8 hours a day, things beneficial, but I want to put it in context. Why intermittent fasting, carnivore diet, carb restrictions works so well right now is when you're in an insulin resistant state, which most of us are, it is the best way to go. And what we're talking about now is once you're out of that state, what's the best? We talked about the Randall cycle before. We'll go over more detail in a moment. But a woman who's cycling, there's a great book by Dr. Pelz called Fasting Like a Girl, explains hormonally, again, When you have a woman, so the basically think about the cycle having 3 parts. The part before you ovulate is the estrogen dominant state. Estrogen loves fasting, loves it. So that's a great time to fast. Maybe eat 8 hours a day, eat 6 hours a day, run marathons. That is a great time to do that, to restrict carbohydrates. Progesterone in its actual development, this is say the next week of the cycle, progesterone loves carbohydrates. So when your body's craving it, give it healthy carbohydrates, yams, complex carbohydrates, nice fruit with berries, that kind of stuff. After you ovulate, about day 21, 22, and you have about a week after you ovulate, then you're back to the estrogen state again, which likes to fast. So this goes through a pretty detailed. But the biggest thing important is it's the working out. We think women jazzercise that. No, it's strength training. That's the best thing to do, lifting weights. Lift weights 2-3 times a day, lift them heavy, the proper technique, and walking is very important. And there's HIIT. When you look at HIIT high intensity, we're not talking when you do 30 minutes of that. That's something where you do, say, all out 30 seconds, you'd 4 cycles. And you get to 2 cycles, you've killed it. And our body adapts to that. But back to the fasting part, the way this has to work is there's 2 major, I'll say, doorways in our pathology. You have what's called mTOR and AMPK. And when they're in balance, we're in balance. mTOR is when you grow state. The AMPK is your fasting state. So exercise gets to that. When you have those balanced perfectly, more like 2/3 fasting, 1/3 the mTOR growth is probably the most optimal state. But again, the problem, Jim, though, is this idea of 3 meals a day in the food pyramid and 3 snacks, that led to the insulin resistance.
Right.
That led to all this kind of stuff. That's why the fad is those. So anything, I love Dr. Jason Fung's book of obesity. He lets us try anything other than that. So basically, we used to eat, we hunter-gatherers, find things to eat and enjoy and did well. But the sad thing is, Jim, if you go to Europe, there are food here in America that's not allowed in Europe because they don't use glyphosate. Glyphosate destroys the gluten molecule, which leads to these complications. So it's not as simple as don't do this or do this. But I'm a real believer in there's a reason we eat red meat, eggs, and butter and fat. That's been shown to good. Avoid simple sugars. Avoid omega-6 or seed oils. You do that because that's oxidative stress. You can do that. You're beneficial with what you do.
Probably don't know the answer to this question, but does fasting negatively affect female metabolism?
It sure can, the wrong part of the state again. And that's why, how do you know if a woman's not having enough calories? Her cycle stops. If you get I listened to a world famous Stanford trainer on Dr. Uberman's show last week, and even their Olympic athletes, when given the proper food and trained properly, will keep their cycles. The cycle is a phenomenal barometer of an overall woman's female's health. So we think amenorrhea is all athlete. It is not actually. There's benefits because you want to make sure you have the right substrates, the right macros, the carbohydrates, the protein, and the proper carbohydrates is very important.
As we're on the cycle topic, does testosterone help with cycles?
Yeah, again, I find my endometriosis patients, I find my PMS patients, because testosterone is an anti-inflammatory hormone. And these processes that lead to inflammation, i.e. endometriosis, there's basically 2 major what's called cytokines. Interleukin-1, that category, it causes inflammation. Interleukin-10 is the anti-inflammation. And the very important thing, acute inflammation is life-saving. Chronic inflammation is life debilitating, right? So it's the proper balance. Everything's in balance. And what happens to our body, we get so skewed and out of balance is when our homeostasis is messed up, all these disease processes occur. And that's why it's important, I think, to understand the science and how the body works and understand where like the food pyramid, Jim, that came from a Sweden study before it came here in 1977. And it was a study, how could they sustain a population on caloric intake without any red meat? That was the study. It was, how can we sustain a population in a state of economic downturn, food downturn? It was not a healthy diet. And we've known these studies from the 50s what sugar did to our body.
Let's talk about PCOS. Why don't you explain what it is? And the question is, can testosterone help?
This is the thing that's so, again, we hear PCOS, we think of hair, acne, and testosterone is the cause. I was trained by like the world experts in this stuff. And PCOS, there's a the way the ovary looks, it looks like a golf ball, very hard. It's called the Stein-Leventhal. And back in those days, in the 30s and 40s, what they did was to make the ovary ovulate, they would wedge out a piece of the ovary, releasing the egg. By the time I started training, we'd use these lasers and burn holes. And Dr. Lobo at Columbia, phenomenal, wrote papers on, professor of mine, talked about those kind of data, but he called it hyperandrogenic chronic anovulation. They didn't call it PCOS because it's a sugar disease. It's basically a part of metabolic syndrome. High sugar causes high local insulin, which led to high local androgen. Now that I've done this for 13 years, I don't think it's testosterone that's the androgen. I think it's androstenedione, which turns into E1, not E2, because we have people, classic PCOS, overweight, hirsutism, skipping their periods, and their testosterone is 0. When I tell them to lower their sugar, so I give them testosterone, which makes, by the way, their insulin receptors more sensitive. Studies have shown in men, it actually decreases hemoglobin A1C by 17.6% in 6 months. So if you make the insulin receptor more sensitive, you lower the sugar, therefore then what happens, it's not a structural disorder, PCOS, it is a physiological disorder. The idea of, well, if you look at an ultrasound on an ovary, you should have different size cysts throughout the ovary. Those are eggs, all different sizes in their maturity rate. But in a PCOS ovary, it's just on the outside, like a periphery of the same size cysts that are too small to ovulate. That's so again, but you lower the sugar, you lower the insulin, then you ovulate. That's why metformin, which lowers sugar, was actually used for infertility for PCOS. So it's a sugar disease, Jim. Because a third of PCOS, Southeast Asians have a high PCOS rate, but they have no hirsutism. Because in their skin, there's an enzyme called 5-hydroxylase that turns testosterone to DHT. They don't have much of that. So they don't have it. More Mediterranean women do. So that's also a thing to do with their own genetics. It's not because even their diet. But PCOS is on a rampant in the last 30, 40 years because metabolic syndrome, insulin-resistant diabetes is up.
You mentioned metformin. What are your thoughts on that?
I think Dr. Attia had some good trace stuff on that. And there's what they found in English studies where they were finding diabetics on insulin, on metformin, live 7 years longer. There's a trial going on, I think, in Cornell right now, looking at non-diabetics on metformin. What it mimics, though, Jim, it mimics fasting. In fact, there's a great paper came out a few weeks ago showing fasting itself was superior to metformin. So I think that's to me, that's the answer. But very important again, I want to get this thing. Once you become, Mark Sisson talks about this, Sean Baker talks about this, once you become adaptable to the source you're using for energy, sugar and or fat, then your body will use what it needs for certain times. Certain cells in the body, brain cells, can use ketones, can use fat. But there's Dr. Bacolo talks about the Randall cycle, saying that if you take, this is after you're out of the insulin resistant state, that there's an optimal number for mitochondria to decide, when you make energy sources in the cytoplasm, you make 2 ATPs. When you make it within the mitochondria, i.e. with fat or with sugar in the mitochondria, you get 36 to 38 mitochondria ATP. So it's more efficient. But he has this gate he talks about that when you get over 30% of a fat diet, you could actually lose that Randall cycle. I don't know much about it, but it's making a lot of sense to me. But even Dr. McCullough is very clear on this, is that it's after you're done insulin resistance. We had Dr. Baker on our podcast a few years ago, and I lean more towards that. But I found on my own stuff that I could actually have more energy if I have some simple sugars in the form of carbohydrates from fruit.
Okay. I'm going to jump around a little bit, talk a little bit about the thyroid. We have a question that just came in. Please talk about thyroid medications. Why take thyroid meds if levels are low to normal?
Okay, this is very good. Okay, the brain makes a thing called TSH. That makes, we have 5 hormones in our thyroid, T0, 1, 2, 3, and 4, based upon their intermediate structures. At any one time, the T4 is being made 80% of the time, the T3 is being made 20% of the time. The T3 is used immediately. The T4 in the peripheral, mainly the liver, will convert to more T3. What does T3 do? T3 turns on mitochondria. It's an energy source. I like to do these a little simplistically, but I like it. When you have cyanide poisoning, it blocks mitochondria, basically breaks T3. So that's how important T3 is. To make that formula, to actually make the thyroid in there, you need selenium, you need iodine, you need B complexes, you need C, you need iron. 50 years ago, we ate 200 times more iodine than we do today. Selenium used to be like Brazilian nuts, but the soil dictates all that. So this is a paper done by Dr. Abrams, famous guy in the 70s. He's a mentor of Dr. Brownstein, who's a great thyroid doctor. He said, if you look at laboratory, a TSH under 5, I'll go over the reason why the numbers matter. About 10% of Americans, mainly women, I'll go into the reason why, have hypothyroidism. If you look at symptoms, probably 40%. But 1979 was very interesting. That's when we went from 200 times less iodine. They took it out of our food. They replaced it with another halogen called bromine. I don't know why, maybe cheaper. So we don't have iodine decreased. We know from the goiter belt is we have low iodine. So we started getting more hypothyroid. It actually was an increase in 900% higher in women getting thyroid. And why? Because breast tissue needs iodine. So now you need 3 milligrams a day just to satisfy the thyroid gland. And the breast tissue needs, especially in a postpartum state when you want to make milk. So there's a battle for that. In men, it's the prostate, same type of gland. So now we have a less substrate of the iodine leading to not hyperactivity, hypergrowth of this, leading to hypothyroidism. So what happened was they used to always use armor thyroid, which comes from the pig. And for some reason, the pig's thyroid's T4 and T3 is almost proportional to ours. A company that started making the synthetic version, very interesting. They thought it'd be more accurate giving just synthetic T4. But 2 papers out of Stanford and San Francisco said, no, just the opposite. So it's like, I don't know why they're going to fight over it, but they replaced the one that has no function, but has to be converted. At the same time, they took iodine out of our body. So it can lower the TSH. I find when you optimize your T3, you actually look at the symptoms resolve. Hair growth back, belly fat, bloatiness, cold intolerance. So I think when we look at that, that's the way I'm looking at the symptoms as well as in laboratories.
So when you talk about normal lab ranges compared to what you would look at as optimal for T3 and T4, is there a difference?
Yes. So I look at TSH. They've been in the lab, but they say anything under 4.5 to 5.3 to 0.5. I like it under 1. That's the brain part. The one here, I like the free T4 around over 1.1, the free T3 over 3.5. But very interesting. They're called enantiomers. T4 converts to T3 and reverse T3. They're a mirror image of each other. T3 is the gasoline that turns on the mitochondria. The reverse T3 is the brake that balances it out. And the synthetic version of T4, by the way, converts more to the brake. So I have a lot of patients that their TSH will be in normal range. They still are bloated. They're still cold. They're still losing hair because the reverse T3, I like it under 10. It's above 30 or 40. We put them on bioidentical armor thyroid. You see the T3 go up, reverse T3 go down. Also give them iodine. Dr. Brownstein says you'll see about a 6-month bump in the TSH, and then that will equilibrate out because you got to get rid of all this bromine out of your body, this poison in your body. We have a system in our glandular cells, the thyroid glands, the breast tissue, the prostate, called the sodium iodine pump that pumps in 1 iodine molecule, 2 sodium. That takes about 6 months to balance so you get the optimal levels. It's been shown that with that level, breast cancer in Japan is about 1 in 25. We're 1 in 7. We used to be 1 in the 20s when we had a higher dose in the 50s and 60s.
Obviously, supplements can increase your iodine.
The iodine supplement, and we take iodol, which is balanced iodine together. It's a 50-50 balance. Lugol solution. I do that. I'm big on selenium. I'm big on our B complex and our Cs. Again, when you look at symptoms of thyroid, it's probably 60-80% of us have some symptoms of hypothyroidism. And I think, again, that's a balance with our testosterone. In my mind, to be really simplistic, we're all Bugattis or Ferraris. You need 2 major sources to drive a combustible car. You need a fuel source. To me, that's the sex hormones. The thyroid is the carburetor, and I try to balance that out.
So if somebody was kind of on that borderline, but they didn't want to take the medications.
If they're borderline, Jim, I like to avoid medication first always. I like to go to iodine, selenium first, and repeat in 6 to 12 months.
And then what about oysters and no bread, gluten-free, that
All
kind
that
of
stuff. Again, the gluten is very interesting. The gut has these tight bonds. Leaky gut syndrome is when, if this is the lumen of your gut, these molecules could break through the gut into the bloodstream. What happens when they get in the bloodstream, if they're foreign to your body attacks them. We use gluten as an example. Gluten is a 33 amino acid protein. That's interesting. It appears to have something to do with glyphosate. Glyphosate somehow changes the modulation of that. So when that breaks through, you can actually measure a thing called zonal and oculin in your blood. If that gets high, then your body gets exposed to this foreign protein. That foreign protein gets attacked by your immune system, which it should. But the antibodies that attack that foreign molecule also cross-react to the thyroid. And there's 3 of them. TPO and TGA, if they're attacked, that's Hashimoto's or hypothyroidism. M2, a mitochondrial antibody, that's high. You look at Graves', that's more associated with primary biliary cirrhosis or liver issues, but that keeps an eye on that. So hyperthyroid is Graves' disease, Hashimoto's hypo, but it's like a spectrum. And Dr. Brownstein talks about, he find that by just giving iodine, that can reverse itself. So that's the first line.
Okay. Let's jump into birth control for a second.
Not a good topic.
First question is, when you're on birth control, does the body actually ovulate?
No, what it does is it's called pseudopregnancy. It tricks your body you're pregnant, and it tricks your body you're menopausal. So if you get a person on birth control pills, it's interesting. It's going to show no hormones, so you're menopausal, but an FSH normal, which means you're pregnant. So it tricks the body. So the whole idea behind it is you don't ovulate.
And how does that affect the body then?
Well, the problem is, Jim, if testosterone it makes you feel good, now you have no more testosterone, you turn that off. I find Mirena IUD, but synthetic, there's four generations of progesterones. The 2 and the 4 are the most commonly ones used. But the studies are showing now that they may increase in breast cancer, 18 to 30%. I find about a 30% increase in depression because you're blocking what's called the GABA receptor sites. So again, these molecules are not innocuous. The reason, now again, I'm not talking birth control. I'm not talking family planning. I'm talking overall body. Women having their normal cycles is a sign of good health. And the doctor we heard I forgot her name from Stanford, was talking about they're finding some repercussions of their world-class athletes to get them off the birth control to actually have better peak performances in their events.
Because there are some Gen Zers that are young and they're on birth control to mitigate mood swings.
Again, like
cause acne, things like that.
But again, there's other ways to do acne than to turn off your whole cycle. It's just like the Mirena IUD, they found, in 2 years, you get early osteoporosis. And are you losing that time of making bone? Again, there's a reason, again, and these, when they say they're hormonal, they are hormonal technically, but they're not the human hormone. They're a different shape, a different structure, a different elimination, 2, 4, 2, 16, or 4. All those things should be discussed with your doctor. All these questions, blood clots are increased. In fact, 50% of young women who get blood clots and a birth control pill have a genetic predisposition, one that's being called factor 5, the most common. So these are things we have to ask these questions about.
I'm just looking at the questions. Going back to, if somebody's going to try to get pregnant, they'd want to be off birth control for how many months?
Okay, that's gynecology talk. That's my old house.
It's women's health. So
yeah, you can, but the thing is, you should have your cycle by definition back within 6 months. Most women, the reason why it can be sooner than that, because you think about it, the young woman misses her birth control pill, she has a chance to become pregnant. Because why? You have a chance to ovulate. Because the pill, depends on you, but the half-life is about 40 to 50 hours. But you want to get, the first period is usually not an ovulation bleed, it's just a withdrawal bleed. So you want to build that lining up, then have a nice withdrawal bleed so the lining's thick enough to actually take a nice healthy baby inside the implantation.
Okay.
But if you don't have it within 6 months, okay, then you should have that worked up. And thyroid disorders, a prolactinoma, there's certain things you look for to see why you're amenorrheic. And this is, again, back to a Stanford professor who's very smart on this. If you're taking a pill to mask your irregular cycles. When you get off it, then they're still mad. Now you're releasing them again. So the key is to find the underlying cause first. And in the brain, you have the hypothalamus. Underneath that's called the anterior pituitary. The posterior pituitary has 2 hormones. The anterior has 6. And they have to be, they're squirted out by these things called releasing factors, certain pulsatile ways. And if something happens in this brain, head trauma, car accident, you bleed a lot, called Sheehan syndrome, or a tumor grows, it will put pressure on those and the pulsatile frequency will be messed up. And the first sign you see in a woman is lack of a cycle. So when you think about up there, the first thing you think about is, are you making milk you're not supposed to make milk? That's called galactorrhea. And the first thing you think about is what's called a prolactinoma, a brain tumor in the anterior pituitary. That's the most common benign tumor that's used with a medication called bromocriptine that will actually suck that up, or Dosinex. Will suck it up with medication, no surgery necessary. Also, your thyroid can be thrown off. So that's why you look at other symptoms on your thyroid disorder to see. That's what we do at Optimal Bio. We check all those hormones to make sure that we know if the cause is the gonads, the anterior pituitary, or the hypothalamus.
Okay. We're getting a request to talk more about perimenopause.
Talk more about it?
Mhm.
Okay, more about it. It's real. Okay, number 1. Starting at the age of 40, women start losing 0.5% of bone per year before menopause happens. In menopause, a woman loses 5% of bone every year. By the age of 70, 70% of women have broken vertebrae. Osteoporosis is the number 9 leading cause of death. If you go on testosterone pellets, you gain 8.3% of bone per year. So why do you wait for the bone to break and take these medications so you can prevent that? So here's the thing about menopause. It is real. I understand people think it is a natural occurrence, which I agree, but the sequelae of not having hormones leads to diseases. We're not going to cure not having breast cancer or heart attack or dementia, but can we push it out? Can we push out our health span longer? And I believe you can by being optimized. And I'm doing it all the time. I'm doing this all the time. Would you ever tell a type 1 diabetic, you're past the age of worrying about insulin? Never, because it would lead to death quicker. No hormones lead to death. It just takes longer time to do that. So again, my whole goal is to avoid the sequelae of aging, the bone, the muscle, the heart. It's shown if you work out as you age, you lose 1 or 2% of your strength as if you work out. Well, if you have hormones or a youthful number or an optimal number, you gain strength as you age. Again, look at the diseases. Dementia, 75% of all Alzheimer's patients are women. Women are 3 times higher for dementia because when they lose those hormones, and the brain is 75% cholesterol by weight. When you get rid of the healthy stuff, the healthy fat, healthy cholesterol, this can't talk anymore. So I'm hoping women don't have dementia, don't have loss of words or brain fog. And if you start seeing those signs, we have every single day. Oh, cool. Like people say, I got words back. I understand what's happening because there's a phrase called neuroplasticity. It actually makes these hormones during the perimenopause age, instead of shrinking, it actually grows and it plumps, and the synapses get tighter together. And the non-genomic part of the testosterone and estrogen actually make the brains talk better. So perimenopause, it's just like all these symptoms, like say, which symptom's the worst, whichever one bothers that woman. And again, the whole idea is to give a full tank of gas. And then you eat right, sleep right, the things we talk about all the time. But you need to have the full tank of gas in optimal numbers to decrease those sequelae. The big thing, Jim, that bothers the crap out of me with perimenopause and menopause is this. The treatment of choice are antidepressants. That's the standard of care.
Which does?
Numbs their brain. That's all it does. It just numbs them. It's like, yeah, you're crazy. Here, take this. Now, there's probably 10% of women need it, or men need it. I got it. But not 85% of us. Let's optimize your levels first. Optimize your thyroid, optimize your blood sugar, optimize your cortisol, whatever these things are. We would never say, live your life with no cortisol. You die. But say it's okay, live without the most abundant active hormone in the human body. Don't worry about that for half your life. Makes no sense to me.
Obviously, too, with increase in testosterone, you're going to develop, especially as an older person, a little more muscle around those bones, which then helps prevent falling.
It does 2 things. Makes more bone, makes more muscle. Brett, what about cancer? Dr. Glazer, again, this is great literature. She showed that by going on testosterone pellets, she decreases breast cancer by 40% in her Ohio population up to 60%. Just the opposite we hear. The classic WHI study in 2002 said hormones cause breast cancer increase 24%. No, they gave estrogen and they gave estrogen and they did not give progesterone. One arm was Premarin, which is pregnant female hormone. And by the way, that arm did not increase breast cancer. The other arm was Premarin plus Provera, synthetic progestin, that increased to 24%. And even that was skewed based upon age population. A great book called Estrogen Matters talks about that. So that paper has been destroyed in the last 20 years, but nobody looks back at the current literature. In fact, Dr. Fioranero in France did a study of 134,000 women. He gave them menopause women. He gave them estrogen and progesterone, estrogen and medroxyprogesterone. The estrogen and progesterone arm decreased breast cancer 10%. Get that? Decreased it 10%. On top of Glazer's papers, 40 to 60%, increasing more with testosterone. The medroxyprogesterone arm increased it 69%. It's synthetic. That's why it's really, really important to understand the bit. We've shown vitamin D decreases recurrence of breast cancer 400%. These things all work in unison, Jim.
Got a simple question for you. The risks and benefits of hormone therapy.
I think we just did cancer. Well, that's one of the best ones. So the risks, we're talking human physiological hormone replacement, not non-human, not super physiological. The very, very first paper was 1985 on menopausal women. Again, the seminal event was looking at symptoms, and that paper showed testosterone level was superior. 2005 was the next paper out of Germany that showed a woman with the lowest 20 percentile had double the risk of overall mortality. Double in the bottom quintile. When you increase it, you actually reverse that to double your cardiovascular benefit. Dementia, same thing. It appears the brain has that E2 alpha receptors, and testosterone and progesterone are very protective of the brain. So again, it's what's used and at what optimal levels there are. So there is no risk of blood clots. There is no risk of dementia. There's no increase in breast cancer. Those are all, I call them benefits, because it decreases, it doesn't change it. In my new book, Restore, I have a whole section on women, menopausal women who are not on hormones. People don't realize a woman not on hormones, a menopausal woman, has more chance of a sudden heart attack than a man, more chance of recurrent heart attack of a man, more heart attack disease than a man. We always think older men get it. Women go from protective to non-protective like that. Again, the big thing for me is women's neurodegenerative diseases and cardiovascular disease.
Okay.
And then osteoporosis. Again, a number 9 leading cause of death can be limited to almost zero by having the bones just gets, again, these medications for osteoporosis, they make bones hard and brittle. And after 5 years, they actually increase hip fractures and jaw fractures. Bone is not supposed to be hard and brittle. Bone is very strong and pliable. And what makes bone grow in a woman is progesterone and testosterone. What estrogen does slows down what's called the reabsorption of it. So because our bone, our skeleton is remodeled 25% every year. So every 4 years, we have a new skeleton, our whole new skeleton. It's a very active because it's where it stores our calcium. So these are things that I understand. It's preventive is the aspect I'm looking at.
From the getting therapy, how long should one be on hormone therapy? Obviously forever.
Back to my story again. Why would you ever stop insulin? We have our oldest person right now, man, is 91. Our oldest lady's 88. We have one of our patients, he's like 93. He's been on testosterone for like 50 years, waiting for us, obviously. And it's like, it's like, I told him, he's like my role model. He's insane. So it's being, again, with that, it's not a magic pill. These are great hormones. They help your body, but you still got to sleep. You still got to work out properly. You still got to eat properly. You still got to release stress. That's all together. And then, how I believe when God's in charge, he's to start the heart, stop the heart when he's done with. The key is when we're here, be as healthy as possible. But Dr. T has in his book too, it's very important to understand that the idea of being healthy does not increase the quality of life, but for a shorter time. It actually increases the quality of life, plus the length of life. So the quality and the health span can be concurrent. And that's what I believe we do.
If one is on therapy and is menopausal, let's say they're on for 10 years and they decide to go off. Will the hot flashes stop then?
No, no, no. The hot flashes restart again. So they're going to go through menopause again. The average length, I'll say, through menopause is 7 years. But I want to be clear on that. Menopause never stops until you go to heaven because you're never making hormones again if you don't do anything. But you'll learn to deal with the symptoms. We have a 90% retention rate because people they see the difference in the benefit. That's what makes it so cool. And I don't know. So like, we really do. As a surgeon, I had a problem. I fixed it. They felt good. Same thing here. You do the procedure and they come back. That's why you may come in for this symptoms. They come in for that symptoms. But at the end of the day, I'm judged by their symptoms. It sounds sort of nebulous, but it is to me root cause medicine because I'm giving the body what it needs to fix itself. And how do you know it's working? I'm sleeping. My energy level's back. My waist is decreased. My strength is up. My relationships are better. And that's why I get so much this gratification I get from helping people is insane.
Back to hypothyroidism. Can it cause health problems like infertility, obesity, and joint pain?
Yes. See, again, if a woman stops skipping periods, one of the very first parts of the infertility workup is to check the thyroid out fully. Again, a sign of a healthy woman is having normal cycles. The side effect of having low T3 hypothyroidism will be things that the thyroid really does. The mitochondria energy source, so energy, storing fat. We've done studies on white fat and brown fat before. Brown fat has more mitochondria, so more energy source. You start seeing, again, I'll give you an example. Hair is not necessary for life. Thank goodness I'm losing some hair and you do it.
I lost mine.
When you start losing hair in the eyebrow, Hithrow syndrome, when you start feeling cold all the time, these are belly being bloated after you eat. These are low T3 signs. And that's why I think it's important as a clinician to listen to the signs. You come to me and you're cold, your hair's thinning, your eyebrows are gone, you're bloated after every time you eat, and your labs are with normal range. I go, oh, you're fine. Your range are normal, but you're like, dude, what's wrong? Because these ranges are ranges.
Right.
Nobody knows their body more than you know your body. And you know the generic you. You know how you're supposed to feel. And my goal is again, I love getting older and aging, but I want to age, I hope, as disease-free as possible. That's the goal.
Yeah. What's beautiful about Optimal Bio and you is the fact that you treat the symptoms. You don't just look at the labs.
Right. But it's symptoms at the root cause. So it's like, I use the example again, you're driving
Well, say you treat the symptoms. You're listening to the patient.
Exactly.
Yes.
Because it's very important, Jim. It's like you have your car, your dashboard, and all these lights go off. You got to find out where that red light goes to, or you put a piece of masking tape over it. The masking doesn't fix it.
Right.
And that's what drives me crazy with just masking these things, because especially we had a woman last year about my age in the early 60s. She comes back, she goes, everything okay? She goes, I just want to tell you, I felt I've been underwater for 60 years. Now I'm out of the water. That's the way she explained it. It was beautiful to hear. And you're like, wow. Because again, you know what you're supposed to do, and you're told these things. You have all these, another medication. I mean, they're important. I'm an allopathic doctor. That's certain reasons why you use them. But just to keep giving them as polypharmacy is not, the body's made to do a lot of things if we have the right food sources. That's why, have the cow eat the grass and then we eat the cow, right? Have the chickens eat all this stuff on the ground, then we eat the chicken or eat the eggs. There's the stomach of a cow is 4 stomachs that's built to eat grass. This is important stuff that we got to put together and use our head logically. It's just all biochemistry applied.
So since we're talking about food, let's move on to a couple questions around diet. What diets are best for postmenopausal patients?
I find postmenopausal patients to be a little easier than cycling women again, because you don't have to write their cycle. And I find that again, once you are adaptable, being either sugar or fat for energy, then I'm going to lean towards the carnivore diet. Jason Fung's intermittent fasting. I find about an 8-hour window, but I have added more fruit back. I think a red meat, eggs, beef, any type of meat, and eggs, and a little bit of fruit is my cup of tea. The problem with vegetables, I find, and Dr. Baker talks about, he goes, vegetables, their only defense system is to make poisons to hurt you. So for taste purposes, but I love his book. Carnivore Diet is phenomenal. I love it. But I do like a little sweet, little candy. We talked about it on the show. He hasn't had a cupcake or whatever in 5 years. So I think it's in moderation, but I think What Jason Fung talks about in his books, Obesity Code, Diabetes Code, is eating, basically 8 hours a day and 16 hours off gives you a lot of flexibility, which you pay with your diet. So if you want a meditating diet or want more stuff, it's the flexibility of the mTOR and the AMPK being turned off and on properly. So that's my favorite.
Okay. Should workouts be different depending on age and cycles?
Very interesting. We listened to a good podcast the other day. Especially women, they should have carbohydrates, low protein before they work out, regardless of age. There's some studies that show as you age over 50, it might be good for men to work out on an empty stomach. But the more I'm listening to it, basically you'll find your stuff. But we know that the post-workout meal for a woman is extremely important to be done within the first hour. Men have up to 3 hours. What you want to do is you really want to give your fats and proteins back to your body as fast as possible. Because the whole idea is when you're working out, it's working out, it sounds crazy. It's not lifting from muscle and bone. It's stressing the central nervous system. It's stretching the axion of the myelin sheath of the nerve. It's like the body will do the minimal amount of work to lift something. So the goal is to break down the nerve, the central nervous system first. So when you work out, it's harvesting more of the fibers. One of our patients, he's a public figure, he talked about this. He trains a lot of world-class athletes. So what he does before he even starts to work out is he holds a stretch to failure and a squat to failure so that the central nervous system is woken up before the workout. And we heard that lady from Stanford talk about that. So so working out is a central nervous exercise.
That is very interesting. And I think also she was stressing too that because you're waking up and you're stressing the central nervous system, you have to be careful that you don't overdo it.
Right. And that's the thing that happens is people think, I'll work out harder. Then you make more cortisol. Make more cortisol, so more store for fat. And cortisol peaks in the morning about 8 o'clock and then goes down the day and when you're asleep, it replenishes it. And when cholesterol is highest, cortisol is highest, testosterone is lowest and vice versa. And their precursor to all this is cholesterol. So low cholesterol affects cortisol, sex hormones, brain, everything. Our body makes 2,000 to 4,000 milligrams of cholesterol every single day. Cholesterol is not the culprit. It's vegetable oils, omega-6s, and sugar that oxidizes the LDL, not the LDL in itself. So that's why you put it all in context. But yeah, the high idea of the body, Jim, I like working on an empty stomach when I do first thing in the morning, myself personally at my age. But I do eat faster and replenish. And interesting too, I always thought we eat a gram of protein for every kilogram we weigh. But Huberman was talking about a gram for every pound we weigh. So that's 3 times more. It's 2.5 times more than I used to thought. So I've been trying to increase protein tremendously and fats. But the fats are ghee, butter, tallow, animal fat. Again, I can't. These artificial like margarine is candle wax. Our body can't metabolize that stuff. It's poison.
No, we were told to eat that over butter back in the 90s and told to stay away from cheese. And I just saw an article today that raw cheese is actually phenomenal for you, especially for your gut.
And it is because of fermentation, but it's what's the word? But European cheeses are different than American cheese because it's not pasteurized. Pasteurization ruins all the benefits of our milk and our dairy.
I was going to say, because if you have raw cheese, it can't be pasteurized,
Right.
correct? Yeah. Different types of workouts. Or obviously, when you're 70, you might work out a little bit different than when you're 60 and 50 and so on and so forth.
To a point, though, I mean, again, strength training is the core. And she was talking about form. Get the form down, you lift more you do. Think about it. The number 4 cause of death, I got this from Peter Attia's book. Fourth cause of death over the age of 60 is falling down. The most number one place is the toilet. So it's very important, squatting and deadlifts, learn how to move your core and your bottom is most important. So I think those should be non-negotiables. It doesn't mean you have to deadlift 500 pounds, but air squats, proper form, proper balance. I was reading a great article on how to increase proprioception of your foot as you age, rolling a golf ball on your foot a couple minutes a day. Things like that, standing on one leg with your eyes closed. All these things are important, these balance exercises. Again, back to Peter's book, he says the number one thing to measure longevity is grip strength. and hanging from a bar for 2 minutes is like Olympic athlete stuff.
Yeah.
So these are things we should all add to it. But Jim, this is important. When you listen to Huberman and Atia and the guy that I train with, you really got to find the real trainer, Jim, because people get into little fads and stuff. They're a core principle. Now, we might know more science over time and learn more science. That's why I think the internet is phenomenal. The Dr. Hubermans, the Atia, those things are great things out there to learn. They may differ a little bit in X, Y, or Z, but they're all doing their research. But if you just get I'm a trainer. Really, where'd you train at? It's important to really ask these questions. And maybe an Olympic athlete, but that ain't for you. And we got to make sure, because functional strength is the most important. So I find deadlifts and squats, the core exercises in the chest and back, and then I think balancing exercises. Band work is phenomenal.
So let's talk about the female pellet compared to the male pellet. Obviously, when you're being placed, you can't see what's going on. Is it one size fits all?
Nope.
Is there differences? Can you just walk through that for
First
our
off
females?
is a woman, her hormones will change based upon her symptoms or age. But basically think before menopause, they're getting only testosterone. When perimenopausal comes, that's usually a hypoprogesterone state. We might start adding progesterone as well as at the same time. And again, estrogen, I'll be clear on this. I think some people treat with too much estrogen too fast. I think there's a balance for estrogen. And it's just not giving the estrogen pellet. It's, are you giving the probiotic? Are you giving the DIM? Are you giving these things that helps the metabolization of your estrogen? So with a younger woman, it's primary testosterone. And again, in physiological levels of 3 or 4 generations ago. The pellet itself is 3 millimeters in diameter. The length based upon the dosage. And so the trocar we have, which is a metal straw that goes under the skin, about 30 degrees under skin, about 4 inches in, but only about a half inch underneath into the fat area. The lumen is 3.1 millimeters, the lumen. And so that's what goes. So I make it about a 2 millimeter incision. And after I numb and clean everything, I place the trocar and I separate. As I place it inside there, I rotate so the skin, even though this incision is a little bit smaller than the trocar, it helps separate as I move it to keep the scar as small as possible. And then we can put all the pellets in one trocar, one side and pull it out. A man, it's 4 millimeters in diameter, the length change. They're usually 12 millimeters in length. And I usually give 3 rows of them, but I use the same incision. I make it 3 millimeters. I keep in the middle, then I rotate it out about 70 degrees each side so that they're spread out, but they're in one, it's one incision, but I made 3 different tracks.
And
then the dosage is individualized based upon their symptoms, their age, their body size. And we have an algorithm that's been used for 50 years by now. We've fine-tuned our algorithm within that algorithm. And based upon that, then we get labs in 1 month. We know it peaks in 40 hours, but I get it in 1 month because I want to see that steady state release and see how that person metabolizes it. Then I check again in 3 months for a woman, 4 months for a man.
And post-placement, less adverse events with a female than a male?
Yeah, the big adverse effect is that you can expel a pellet. And it's funny, is it's like 3 to 4 weeks later. It's not immediately because it has to work its way out. A woman is about 1 in 1,000, if not less than that. And a man is less than 1 in 100. The national average, depends what you read, the classical paper in Germany was 12.7% of men. Here in America, it's more like 7-8%. But we're less than 1% for that. It's usually going to listen to me. Got to watch deadlifts and squats for a few days because that could pressure on the gluteus medius and maximus to actually cause this pressure to pop this body out.
And obviously, Optimal Bio treats about 60% female and 40% male.
Unless you're Southern Pines office.
A lot of military down there. What are some of the common things when you're doing consults that a lot of the females are concerned about
Jim,
that might be different than what we talked about today?
Jim, I don't want to make it like a cookbook because it is, everybody's different, but it's the same stuff. And they all think it's normal. I'm tired all the time. I'm tired after lunch. I'm tired in the morning. I'm groggy in the morning. Gosh, my brain's, maybe fog's not the word, but I'm forgetting words. Yeah, I'm nervous on things I used to not be nervous about. I love my husband, but I'm just not desired. It's the same thing over and over again. It's like, again, it's like getting mad. It's like bringing your car in and saying, and it doesn't run. And you go, but I wash it. I put air in the tires. I wax it. And the first thing guy goes, did you check the gas? Because that's the first thing we should check. Then you could evaluate how it runs. Then you could evaluate the other thing. So what's really cool is these symptoms are, and what really got me is this, is we consider those normal. And because things are common, to me, does not make them normal. We're a sick population based upon these. Again, I'm not saying somebody is some secret castle trying to kill us all, but there's, I think we've had 85,000 new chemicals released in the environment since World War II. We have no time for those kind of studies. The studies are going on now, right? So we have to ask our questions. It's not in people's heads. That's the biggest thing I get, Jim. It's in their head. Here's your Zoloft. And again, that's sort of like poo-poo Zoloft. There might be a place for that, but not the first knee flux reaction. Let's check how you're sleeping. Let's check, is the computer on? Is the TV on? How's your circadian rhythm? Let's ask lifestyle changes, ask these questions. And then more importantly, listen, because them talking, you're going to have, we had a case presented, you and I, on Tuesday, and they presented the numbers to me. And before they got the numbers, I told the body, because I knew off the bat,
You did, yeah.
because I know what that type goes, because that's what I know what that looks like based on those numbers. So that's why, I love our training, our place we have, because again, I believe that we're based on all science data. And that's why it's important to listen to the story. We're never anybody's first doctor. We're their 10th, the 11th. They love their primary care doctor, but they won't listen. Hear it all the time. Because I was that doctor.
Mm-hmm.
I was him. And I wasn't going to even try. If I'm always reading this, I'm not going to know what's over here. I started reading what's over here. And I go, oh, I missed something. And I don't want to miss something.
25 seconds left. I think we've exhausted the majority of the questions that haven't been repetitive.
Well, I hope, Jim, we're going to do is, hopefully we're going to maybe twice a month, we'll do a question and answer live for you guys, because sometimes we get a thing is we have one consult fee for their whole life. We're into consults. I want to make this very engaging for out there. Just, if you're afraid to ask questions or afraid to know what to ask, hope this helps them ask questions of their doctor.
As always, 60 minutes of chock full of information. Thank you, doctor.
Thank you.